thanks to the organisers for inviting me to speak about prostate biopsies and to provide an update from a urological perspective. It's been an important 18 months for prostate diagnostics in general and prostate biopsies in particular. We now have level 1 evidence, randomised trial evidence, which has laid to rest some of the myths surrounding the optimal biopsy approach and provided the evidence we needed to make informed decisions about how best to do these biopsies. But first, I want to declare some interest that I have relating to this topic, which I trust listeners will use to filter what I say in this talk. I received training to do LATP with Precision Point from the company that distributes these devices in the UK, enabling me to be one of the first to do LATP back in 2018. A substantial part of my private practice is performing LATP, and I am a co-author of the Trexit paper, which I'll come back to shortly, as well as being a co-CI of the Translate trial. Also, this may be relevant. Here's what we're going to cover over the next 10 minutes. A quick reminder of the 2 approaches to prostate biopsy, a summary of the recent high-level evidence, some tips and tricks as to how to perform LATP well, some pointers to future directions of how we might use prostate biopsies in next-generation prostate diagnostics. I'm not going to cover MRI fusion, which will come in other talks. Many listening will be fully across this debate, but just as a quick reminder, there are 2 approaches to prostate biopsy, centering on the route that the biopsy needle takes into the prostate. The traditional method since the late 1980s and the introduction of transrectal ultrasound with needle guides was to pass the biopsy needle alongside the ultrasound probe and into the prostate through the lining of the rectum. Another approach that was available during this time was through the perineal skin, but was thought to be more difficult to perform and painful and therefore required general anaesthetic. Around 10 years ago, clip-on probe-mounted devices were developed by Matt Alloway and others, which made the procedure less complicated and offered the potential to perform it under local anaesthetic alone. The Trexit movement was set up in 2019 by some thoughtful urologists who I admire and respect. This movement, mimicking the topical Brexit neologism, proposed a wholesale shift to TP prostate biopsy by 2022, but interestingly, in the absence of any randomised trial data, mainly due to concerns about the risk of infection through transrectal use. And the movement was largely successful, as demonstrated by this biopsy trends graph, thanks to Jim Adshed and Rick Popert, as well as the BXDX folks for this data. But you can see that there are other factors that may have been at play, such as the celebrity impact of Stephen Fry and Bill Turnbull being diagnosed with prostate cancer, and COVID also had a big impact. In the past 2 years, 4 substantial randomised trials have reported their findings after investigating one-to-one comparisons of the 2 approaches to prostate biopsy. I'll go through these in a bit more detail shortly, and I'm going to use some one-slide summaries, which I hope will be a useful way of summarising these. Probe PC reported first and found no difference in infections as primary outcome. But there were some issues around trial methodology. For example, a coin toss was used, and also the fact that over a quarter did not have MRI, and so questions about how representative this is of current practice, and the composite endpoint, infection endpoint, was deemed to be quite complicated. Prevent was next and also found no difference in infection. They also reported on detection and found no difference there either. A couple of things to highlight was that this study used targeted rectal culture prophylaxis for the trust group, which may not represent normal practice. And most importantly, due to some quirk of the NIH funding model, the study reported before recruiting the numbers of patients required by the power calculation, and therefore was underpowered for its primary outcome. Perfect was the first to report on cancer detection, and perhaps surprisingly opted for a non-inferiority approach. With only 250 men recruited, they concluded that non-inferiority was not demonstrated, meaning that LATP was actually worse than TRUS. Many of us think this is an artifact of an underpowered trial, but it may be due to TP missing posterior or peripheral zone lesions due to the rectal dip. We'll come back to that. And so then, to finish, we have the Translate trial led by Richard Bryant and myself. This was powered for detection, but also investigated infection, tolerability, and cost effectiveness as secondary outcomes. In summary, we reported increased detection of intermediate and high-grade cancer with LATP as the primary outcome. But while infections also favoured LATP, it was more painful for patients and, in the NHS at least, unlikely to be cost-effective due to device costs and the longer time taken to perform the procedure. In conclusion, most recent guidelines do favour LATP due to slightly improved detection and, importantly, because of antibiotic stewardship issues reflected in the most recent EAU guidelines updates. As trialists, we are grateful to our UK guidelines for not coming down one way or the other before the trials were completed and encouraging clinicians to support the trials. The differences are not as pronounced as we once expected. And if people are going to switch to TP, then it's vital that we take seriously the possibility that patients will find this more painful and work out how to do these biopsies as well as possible. So that's what we're going to talk about next. So tips and tricks on how to do a good TP biopsy. I'm going to whiz through these key features of what I think enables a really efficient LATP prostate biopsy. And we're going to start with preparation. A key feature is the ability to perform these in the outpatient clinic. It really lowers the stress levels for patients. The vocal anesthesia, if you like, is much more straightforward in clinic than in the operating theatre. We lock the door. We tell them that we lock the door so they are assured of privacy. I put a picture of a Scottish beach on the ceiling and asked them to guess at the end where it is. Many guess somewhere in the Caribbean, and I take great pleasure in saying that it's actually from my home country of Scotland. It's just distraction. The usual stuff that we know is important for local anaesthetic procedures. Now, one of the big problems with LATP is air bubbles. If you get air bubbles in and around the transducer or in the rectum, you basically have to start again. There are a couple of elements to this. One is when preparing, making sure that there are no bubbles between the transducer and the end of the sheath. And that's partly about how you prepare the gel. As you can see, I'm worried about air bubbles there, and I'm pushing it down before placing the orange elastic band above the bubbles. A problem with the biplanar probe is the long sagittal crystal, which gives more to be interfered with by bubbles. A little more on air bubbles and how to ensure you don't get air bubbles in the rectum this time. The order of things is key, making sure that there are no bubbles in the tube of jelly when you put it into the rectum, and then to do that bit before doing the perineal prep. Because if you do the DRE, I think you smear fecal flora onto the perineum. So a bit of jelly first, double gloves, and then the DRE, and then the rest of the tube goes in after that. So let's go on to local anaesthetic administration. Nice organized trolley, 2 needles, one for skin with deeper infiltration from a spinal needle. Is 2 halves diluted, and I use 5 mils of 2% lidocaine diluted to 15 mils in each syringe. I think it's really helpful to bend the needle sideways. The skin infiltration is really key, and you can do that well or badly. I find the bend helps get that local anaesthetic down towards the anal verge, and those of us who perform this recognise that much of the pain comes from insertion and movement of the probe. There are different types of needle guide, and it's important to be familiar with the one that you use. In these videos, I'm using the precision point, and the question then is which hole to start with. I tend to start with the second hole, and you can see the little technique here of putting your little finger in and then plonk. There we go. It's steady and in place. Nicely designed. And then it's really important to emphasize that we use angulation here, not rotation. This is a key technique point. When you're doing TP biopsies with a brachytherapy stepper, you generally rotate to secure. You must not rotate with a probe-mounted needle guide. If you rotate, you'll lose your vision. Here's our MRI showing a left anterior lesion, and we want to undertake cognitive targeting. What we're trying to do here is essentially follow the kind of map you might have for systematic biopsies with a brachytherapy stepper grid. You take the biopsy, and then note on the axial view where the white spot is where you've taken the biopsy, and then angle across or down as required to traverse the region of interest. Essentially, the cognitive placement is registered, and then further alignment and adjustment required. And with the sponges all laid out in an organized fashion, then if the first effort to hit the region of interest fails, then that biopsy can be placed in a mid-zone sponge, for example. If you get gas from the rectum, it's a real problem. The way to deal with that is what you see me doing here. Gas bubbles really interfering with the view, so you go back in over the top of the air, and occasionally you need to actually fill the rectum again with jelly. So advancing the biopsy needle and then the rectal dip to finish. It's important to advance and then come back to the capsule at the apex, and then fire. Assuming that you do not want to miss apical lesions, this is really key. Obviously, if you want to hit the base, then you can go in further. This is the concept of the rectal dip. Essentially, what we're talking about here is that little dip behind the hump of the rectum, which we have to actually recognize and then point downwards to get into that PZ. So you'll see here I've sort of fired over the top. As mentioned, much of this is on YouTube, and there are other devices, commercial devices available. So I'm going to finish just with a bit of sort of future directions. We use high resolution spatial transcriptomics in my lab, and have used this to map clones in the prostate from radical prostatectomy. And what we showed is that within a biopsy, there can be multiple clones each with a quite distinct expression profile, and that therefore we need to be much more intelligent about how we use the information available to us in the histology that we get from our biopsies. Here's a bit more about how we unpack clonal dynamics in the prostate. Here's a radical prostatectomy specimen, axial cross-section through the middle of the prostate with Gleason grade group 3 distributed across the PZ and right anterior horn outlined in red. But we see from the ST that it's actually made up of multiple clones. And then if we add in the biopsy information that we have for this man, we can see that these biopsies picked up the green clones on that right side, but also on the left, the purple and orange clones. And we call these X clones because these are the ones that have metastasized to the lymph nodes. So now we can see the possibility of differentiating those areas of Gleason pattern 4 that have the potential to metastasize and those that do not. Ideally, of course, we'd like to be able to detect these non-invasively, and an excellent PhD student of ours, Tinesh and Baristan, is developing deep learning models to enable MRI to differentiate these different clone types. Thank you for watching. I look forward to any questions that you might have in the discussion section.